Welcome to Endo Battery, where we are sharing our endometriosis journey and learning along the way. This podcast is in no way meant to diagnose or give medical advice, but a place where you can gain knowledge and information that can help you to not feel alone as well as become your best advocate. We want to learn with you and support you wherever you are in your journey.
Thanks for joining us. I'm Shelby.
And I'm Alana, and we're Endo Battery.
Charging our life when endo drains us. Welcome back to Endo Battery. Thank you so much for joining us today. We're so excited to have Dr. Larish with us. He is a urologist who focuses in endometriosis care. So thanks for coming on, Dr. Larish. If you want to kind of give us a little background of what all you do.
Thank you, guys. It's so nice to see you again. We last saw each other at the Endo Summit in Florida. So really nice to see your faces again. So my name is Yaniv Larish. I'm the Chief of Urology Surgery at Barnabas Health in Jersey City, Robert Wood Johnson Barnabas Health in Jersey City, New Jersey. And my focus professionally is on endometriosis and the urinary tract in both form and function, meaning I specialize in the reconstruction of the urinary tract that's been affected by endometriosis. And I also specialize in restoring normal function to the urinary organs once they've been affected.
Yeah, it was interesting because you were talking about the summit, which, by the way, was probably the most fun that we've had in a long time. I don't know about you, but we came home and our stomachs still hurt from laughing so hard.
And our cheeks were cramping.
Yeah.
That's good.
I know.
We did something well.
Right. Yes. You did an actual panel on this specifically. And what are some of the things that you notice for those that when you're going into surgery and you know that you're going to have an involvement in that surgery? What are some things that maybe the patient describes that cues you guys into?
Yes. So I typically get involved whenever the patient complains of urgency, like that when they got to go, they got to go.
Mm-hmm.
Frequency, meaning they're going more often than their peers. Nocturia, meaning they're waking up in the middle of the night. Feelings of incomplete emptying of the bladder, whether that's perceived or not, meaning whether that's perceived or simply fact is irrelevant. If they feel like they're not emptying the bladder, that's a problem. Urinary incontinence, fecal incontinence. And, it's funny, if you ask anybody with endometriosis if they have urinary incontinence or fecal incontinence, the answer is always no. Nope, I don't have it. But if you ask them, do you wear a pad every day? Yeah. Is the pad wet at the end of the day? Yeah. No, but that's just discharge. No, it's not. There's something else going on there. Or fecal incontinence, do you have a hard time getting clean after you finish pooping? Do you have to wipe 1,000 times to get clean?
Mm-hmm.
And so we have sort of a set number of questions that we ask to sort of figure out who needs to be involved in a case if it's particularly challenging. And obviously that's part of the battery of testing, of questioning that we do. As you know, the problem with endometriosis is, among the many problems with endometriosis, one of the biggest challenges with endometriosis is that there's no test.
Mm-hmm.
Short of the surgical intervention, right? There's no gold standard test.
Mm-hmm.
And so if you don't ask the right questions, it's very hard to get a good intuition or sense that the patient may have it. And the questions are, they're difficult to sort of get to the bottom of, especially if patient's been poo-pooed by a doctor 1,000 times or by 1,000 doctors 1,000 times.
Mm-hmm.
So it's challenging, but I will say that's typically how I get involved, is if we feel that there's a problem functionally, or of course, if we have imaging that demonstrates, obstruction or frank involvement of the urinary tract, whether it's in the ureters or in the bladder, then of course, my involvement is reconstructive in nature.
Mm-hmm.
Right. What do you see though after so you get in there, you do all the work? Are there issues that some of these patients have after that reconstruction?
Yeah. Look, every surgery, there's no such thing as a free lunch, right? And so, to think that we can do surgery without having some trade-off is intellectually dishonest.
Mm-hmm.
Right.
Okay. So you can have somebody who has horrific 10 out of 10 pain 29 out of 30 days a month and fix that.
Mm-hmm.
But that might come at a cost of, not emptying your bladder well.
Right.
Mm-hmm.
Right? If the nerves are involved, and you have to remove the nerves that govern bladder function in order to get relief of pain, you're going to sometimes see that.
Right.
And that's something that needs to be dealt with.
Right.
Same thing with defecatory dysfunction. It's a similar sort of problem. Obviously the way that we do surgery, and I'm part of two, expert groups in working with Dr. Vidali and Dr. Liu. We preserve nerves, and we do a really, really nice job of sort of limiting the negative sequelae of surgery.
Right. Right.
But we also oftentimes see cases that are second opinion, third opinion. They've already had 2 or 3 surgeries. Sometimes the damage is already done.
Right.
Yeah.
And now the job is to sort of undo the effects of a hurricane after it's gone through, right?
Right.
Yeah.
Right.
Rebuilding after a hurricane goes through is not simple. Building the buildings right the first time is a much better way
Yes.
of dealing with the hurricane that's going to
And I feel
through.
like we hear that from, many excision endo specialists is first surgery can be one of the most crucial surgeries if done right for this reason. Because if you go in and things are a hurricane and haven't been done right, when a true expert gets in there, the likely ability to be able to fully help them, maybe like you would have if you got to them sooner, could vary.
Mm-hmm.
Oh, for sure. I mean, look, I just took care of a lady who had, endometriosis surgery by a general gynecologist, and they basically burned her ureter and knocked it off.
Oof.
She basically proceeded to have, stents placed and exchanged in her ureter for 8 months,
Oof.
right, by a urologist and this gynecologist.
Mm.
Till she finally showed up and she needed a formal reconstruction. And, of course, when we went in to reconstruct, she still had all of her endometriosis there. So it ended up being a true extirpative surgery to remove all the endometriosis and then a reconstruction, right?
Mm.
The reconstruction is rarely the reason why we go in. It's usually, part of a much larger sort of intervention.
Mm-hmm.
But that patient, right, had she had the right surgery in the first place, probably would not have needed the reconstruction because we wouldn't have burned her ureter,
Right.
and would have had a complete extirpation of her disease, right, where the chances of recurrence are in the single digits percentage-wise,
Mm-hmm.
Right.
as opposed to somebody who has surgery and 8 months later is still dealing with their initial problem without sort of any resolution.
It's kind of like when your kid gets gum in their hair and you try to dig it out, and there's people who actually can get it out better, or a parent who just goes in with scissors and
Cuts it out.
And it's like, I feel like it's very similar because it's a sticky thing, or it makes it stickier, or you know what I'm saying? Like it has that effect of like cutting the hair.
Yeah, no, the analogy is you either, or it's the opposite, right? Somebody comes in to remove these 3 little hairs that are stuck to a piece of gum and end up shaving the person's entire head.
Mm-hmm.
And you go, well, what was the point of that? That seems unnecessary.
Just in case they have lice.
Surgery is exactly. Surgery is a delicate balance, right? Of doing just enough, but not too much.
Yes.
Right.
In order you have to do a job well done, but it can't be overly done.
Right.
Mm-hmm.
And that's the art of medicine and the art of surgery, is sort of getting a good sense of what that is, a good gestalt of what that means.
Right.
And it takes a long time to get there. I don't think nobody was born with a robotic console in their hand and the knowledge of how to do surgery immediately. You have to be really well trained and exposed to thousands of cases to really get good.
Right.
That's the irony here, right? Is that it takes forever to become really, really good. Unless you're at a center of excellence where you're seeing, that volume day in, day out, and then you get good really quickly. But if you think about the general gynecologist, they're not going to the OR all that often.
Right.
They're not truly trained in excisional surgery. I mean, forget excisional surgery. How about we just get them to do a laparoscopy first, a diagnostic laparoscopy? Even that is a challenge, right?
Right.
Yep.
So, and then forget about urologists. Urologists have zero knowledge of the disease state. Zero.
That's interesting.
Ironically, the urologists have a great opportunity to intervene because many patients with endo will come to the urologist's office and say, hey, I have frequency urgency nocturia, I have blood in the urine, I have my favorite, urinary tract infections, right? I've had 45 urinary tract infections this year. And you go, okay, let me see a culture, right?
Yep.
And there isn't a single positive culture.
Yep.
But if the urologist doesn't say, okay, let me see the culture, guess what? They're going to have 41 or 40, if they had 45, now they'll have 46, UTIs. Because it's not hard to be a good doctor if you're intellectually curious and sort of stimulated by the puzzle solving.
Right.
But if you're a machine that's just, that needs to see 40 or 50 or 60 patients in a day, how could you ever have the bandwidth to be intellectually curious? It's just impossible.
Right. Well, it's interesting that you say that, though, because before I was 18 at the time, and I was seeing a doctor, and he's like, I don't know why you keep having blood in your urine, and we can't figure this out. I cannot tell you how many urine samples I had to give. I became very proficient. It was like twice a week at one point because they could not figure this out, and they were trying to test my levels. And then he still was like, I don't know. I think you have a urinary tract infection. Why is there so much blood in your urine? And now looking back, I'm like, that's interesting. Maybe that's why, because I haven't had one in a long time.
Right. And look, that was at age 18, right?
Right.
So from that moment, how many years did it take for you to get a diagnosis of endo?
From that point, it was 8 or 9.
8 or 9 years. So look at the missed opportunity there, right? To get the diagnosis and treat you and prevent all of the stuff that comes from having endometriosis for 9 years.
Instead, I got a cancer diagnosis or a potential cancer diagnosis.
That doesn't take a mental toll at all.
No,
right,
not at all.
Be told, make your arrangements. I mean, come on, it's ridiculous.
Yeah.
When if that urologist would have said, you're 18, I'm sure at the time you were probably having some cyclical pain. I'm sure that those UTIs were probably related, right?
Yep.
UTI-like symptoms, they weren't real UTIs.
Right.
And when he saw that there were never a positive culture, maybe that should have been a good indication to say, I know that I'm living in my little urology box, right, where I'm not supposed to stray left or right, but maybe I should call one of my colleagues and think about an alternative diagnosis.
Right.
I think that makes me a pure breed in my line of work is that I really enjoy sort of working as part of a multidisciplinary team. In fact, in my opinion, the more experts you have taking care of you, probably the care that you're going to get is going to be a little bit better.
Right.
Yep.
Because everybody brings their own knowledge base and understanding of a disease process. And the sum of all of those opinions together ends up getting you a much better sort of clinical result.
Exactly.
So to me, could I do endometriosis surgery on my own? Probably. I mean,
Right.
I did 2 years of general surgery before I did urology, right? So as many urologists do.
Right.
And so, the technical aspects are not insurmountable. But to me, if you have an expert gynecological surgeon, an expert urologist, an expert cardiothoracic surgeon, an expert general surgeon, expert colorectal surgeon, an expert vascular surgeon, right, collaborating on a complex case, the chances of that complex case becoming solvable are much better than if it's a go it alone type situation.
As we
because
can all
everybody
attest
has
to.
their own everybody has their limitations. Look,
Yep.
if you ask my wife, she'll tell you I have plenty. We all have our limitations.
Don't we all? But
Yes.
some people don't recognize theirs as well. And that's, I think, part of the issue also within the medical field is that so many people have such a big ego that they think they're the best and they won't pass the buck even on the hard cases. So they'd go in and do a disservice rather than, hey, this is fully out of my scope. Here are these names and these people. And I think that's where it gets tricky with endo for sure.
Mm-hmm.
Yeah, I mean, look at the world of urology and its involvement with endometriosis, right? There isn't any.
Nope.
No.
Truly, there isn't any.
It's you.
That's despite the fact that I think it's more than 50% of patients have urinary tract, either dysfunction or urinary tract involvement.
Mm-hmm.
And
Rectum
too. I think, like you said earlier, I think, the constipation or diarrhea piece is a huge.
Of course.
We hear it all the time.
Right. So like you look at that and you go, well, why is it that no urologist is involved in this care?
Mm-hmm.
And the answer is the doctors who would be best at treating voiding dysfunction and defecatory dysfunction want nothing to do with endometriosis surgery. It's true. Urogynecologists want nothing to do with endometriosis.
Why is that?
Because urogynecologists do have a specific subset of operations and patient sort of profiles that they are seeing, right?
Right.
Mm-hmm.
So they're much more likely to see somebody with prolapse or somebody with stress incontinence or even urinary incontinence of the urgent type,
right,
from like bladder spasm. But they're not going to go beyond that and say, hey, why would a 22-year-old have urge urinary incontinence? That's sort of odd.
Mm-hmm.
Let's think about that for a second, right? That part doesn't exist.
They don't want to investigate things. They want to know what they know, and they want to just be able to get in, get out, do what they can.
Well, I don't know if it's get in, get out. I think you said it, right? They know what they know, and they don't know what they don't know.
Right.
And to me, I think that the way that you bridge the gap over the stuff that you don't know is to collaborate with colleagues.
Mm-hmm. Yeah.
And the collaborative spirit in medicine is sort of an unusual, as you alluded to, it's sort of unusual.
Mm-hmm. Yep.
Yeah. There's a lot of egos. There's a lot of stake claiming.
Mm-hmm.
But, if you put that aside and you say, well, what did I get into medicine for in the first place? Is to serve the patient.
Mm-hmm.
And how would the patient best be served? That's by collaborating. You sort of get over that real quick.
Yeah. And the healing.
That's something that to Dr. Vidali's credit and to Dr. Lou's credit, and to really a lot of the doctors at the Endo Summit, I think they all sort of appreciate that and get that and really believe that a collaborative multidisciplinary approach is the way to go.
All of them say it. All of them do, yeah. We've talked about the process of reconstruction, but we also have to touch on the healing, because I think you and Shelby were talking about the effects of the urinary tract and SIBO, how they correlate.
If your nerves are shot, then your nerves are shot, right?
Right.
So I think what I'm sort of known for saying is, if you had a knee replacement or a hip replacement, right, it would be a departure from the norm to not send you to a physical therapist for rehabilitation.
Yep.
Right?
Yep.
Departure from the norm. Like that would be really unusual.
Right.
But in pelvic surgery, we do massive pelvic surgery, and then, there's no physical therapy.
You're on your own.
Yep.
Yeah. Good luck. And that's a problem, I think. And I think as we recognize that surgery, even minimally invasive surgery, right, is still surgery. We still had to stab you 5 times to get all of our instruments in.
Right.
If you got stabbed jogging in the park, you'd be laid up in an ICU and you'd have the news outside, right?
Yep.
Saying you poor thing. But instead, you just get stabbed 5 times in a controlled manner. That's fine. It's no big deal. Go back to work.
Felt great.
Yeah. You're fine.
So
You're good.
Go home.
I think that we don't really, surgeons in general don't really appreciate the assault, right? That the insult that we cause to the body. And, surgery, again, it's another famous saying from one of my mentors. surgery doesn't start in the operating room. It starts well beforehand.
Mm-hmm.
It continues in the operating room, and it continues well after the operating room.
Mm-hmm.
Right? To have a
Mm-hmm.
successful outcome, it really is it's a process. You can't skip any of those parts, right? To have a good
Right.
outcome, you have to have good prehab, you have to have good intraoperative technical skill and outcome, and then you have
Right.
to have a good rehab
Mm-hmm.
Right.
afterwards.
Yeah, and I think what we were talking about, which kind of goes back to all the UTIs that were diagnosed that weren't UTIs, and so many endo patients have been on years of antibiotics for these said not UTIs that they had been
Sure.
having.
Mm-hmm.
And I think that's what we were kind of talking about, with
Yeah,
SIBO.
sure. I mean, look, we know, right?
Yeah.
There is good data. We know. When I say we, I mean not just the three of us. I mean the medical community at large knows
Yes.
that there are significant changes to the gut microbiome with a single dose of antibiotics.
Yep.
And some of those changes are forever changes.
Yep.
Mm-hmm.
And so to think that we can expose somebody to antibiotics 30 times a year for 10 years and not have a change to the gut microbiome
Mm-hmm.
in terms of SIBO, in terms of altering digestion, in terms of endobelly, bloat, all those things, it's sort of wild to
Right.
think
Right.
that we can wipe you out with antibiotics and everything's going to be just fine when it regrows. In fact, we know that that's not true.
Right. Yep.
So, I think that the connection to SIBO is a real one.
Mm-hmm.
Can I prove that? Probably not.
Yeah.
But
Could do a large
some
case
things don't need to
study.
be proven to
Right.
make logical sense.
Yeah. Well, and the hard part is last year, almost a year ago, before I had my surgery this summer, I was admitted to the ER and I was sent home with antibiotics saying that I had a UTI. And, I'm one that doesn't like taking antibiotics for all the reasons we're talking about because it does mess with my gut. I do lots of stuff to reheal it if I've ever had to be on them. So they're like the last place I want to go. And so once I got home, they were like, yep, you have a UTI. Well, then the next day, the ER called me and was like, oh, actually, you don't have a UTI. So now you can stop taking your antibiotics. And I was so furious because for 2 days, I took antibiotics and also pooped my brains out because that's what antibiotics do to me. And I was so furious. Like, I didn't even know what to say. I was just like, thanks, and hung up because I was infuriated that if that's what they're going to do, they should wait and say, hey, it's going to take 24 hours to run this culture or further culture. We'll call you tomorrow. And if you do have a UTI, then start tomorrow instead of having a patient on antibiotics for 2 days.
Mm-hmm.
And so it's
I
just
mean,
so
it's a
frustrating.
challenge. Yeah, of course. Of course. And, if you think about the number of people who have endometriosis and the number of ER and urgent care visits that they have specifically for, lower pelvic pain,
Right.
and then they're told, oh, you must have a UTI because, why there can't be an alternative, I don't know. But that's what they say.
Right.
So think about how many people are getting antibiotics. I mean, it's just,
Yeah.
it's wild. It's
And then
just
you
wild.
become antibiotic resistant. And then I
Yep.
think when you do actually end up having surgeries, are we seeing more infection because of that resistance? I don't know. I mean, that's all a hypothetical potential situation. I don't know. But I think it is an issue long term. I actually stopped taking most of the antibiotics because I was like, it's not doing anything for me. I'm not gonna take it, And they kept giving it to me and I never took it. I don't think that's great, but it didn't help. So obviously why would I take it? Like, why? I felt awful on it. So
Right.
at that point I was like, I'm not the best person to talk about with this because I was
dealt a lot with it.
I've dealt a lot with it.
Yep.
And I was probably not the best patient.
But you also didn't
Or,
receive the best care.
alternatively, maybe you had more insight than your doctors did.
Yep.
Oh,
So
that's true.
I'm not so sure that that's true.
Right. Yeah. You can't blame yourself when, again, like we've said, your doctor only knew so much and you were there in pain. They didn't know more.
Yeah. I mean, I was just done with it. And I'm not a good patient. We all know. I
I
mean,
mean, I don't subscribe to that philosophy of not a
being,
good patient. It's just not, that's not in my vernacular.
what me telling you no is not.
No, you telling me no signals to me that you have a set of ideas and opinions about something that, needs to be worked through,
Mhm.
right? And talked through. And then ultimately, the person who has agency over your body is not the doctor, it's you.
Right.
Mm-hmm.
And so if you have a set of beliefs and ideas that we talk about, and you are convinced that, what I'm telling you is right, then you take what the doctor tells you.
Right.
But if you don't, that doesn't make you a bad patient. That's probably a doctor who wasn't able to convey the ideas in a way that was cogent and sufficiently explanatory
Right.
to either dissuade you from your wrong idea, right?
Mm-hmm.
Or to, maybe you're right? Sometimes the patient is right and the doctor's wrong. That's not a crazy thing to say.
Yeah.
Right.
So I really don't have that in my vernacular. There's no such thing as a bad patient. I don't believe in that.
Yeah. Well,
Bad patient is one who punches the doctor in the face. That's a bad
that's a bad
patient.
patient.
Yep.
And guess what? That's usually because the doctor deserves. No, I'm just kidding.
No, it is true, actually. There's a few times I've wanted to, but I
Yeah,
held
I believe
back.
you.
I mean, I may be small, but I'm scrappy. So
Fists of fury. Yeah, fists of fury.
I know. I'll use my eyes to
No,
fight
but
you
you guys
instead.
understand what I'm saying.
Oh,
No,
There's no
yeah,
such
totally.
thing as
absolutely.
a bad patient.
Right.
That's an inability to communicate effectively between a professional giving advice
Mm-hmm.
and
Right.
somebody who's asking for the advice.
Yep.
So,
Right.
so, and I think that has a lot to do with, um, again, having the time to sit and talk through
Mm-hmm.
Mm-hmm.
discordance between what the doctor's saying, what the patient's saying. And I'm not sure that reflects anything about good, bad, or otherwise about the patient, right?
No.
Right.
I think that's, if anything, it probably reflects on the doctor.
Well, and it also reflects on past trauma with doctors. So
Yep.
even if you try, a patient could be real resistant because of past traumas with doctors. And I think they're going to be, I mean, I know from in my case, I am more resistant to listening to a doctor because I have in the past and it has not been beneficial for me to do so. So I think that there's a lot of hesitation with patients who have seen multiple doctors time and time again, different day, same answer, or that we're crazy or whatever the case may be. And so you get to a doctor who really truly wants to help, and it takes pulling out all the stops to get us to a place where we can trust that what you're saying is valid or that you know what you're talking about because of all the past trauma with doctors. And so and part of that is founded and part of it is we kind of have to go in with an open mind too. So as a patient, but that, I mean, that is the reality of why a lot of times I'm more stubborn with my care and treatment. That's a whole nother can of worms that I don't think we have time to open up. So I'll leave it at that. But what are some ways that you find helpful for endometriosis patients in trying to alleviate some of these symptoms, uro-wise, until a surgery or until they can find a specialist? Because not everyone has that accessibility right away, especially because we do have people from multiple different countries listening.
Sure.
What are some tips that you have from your standpoint that would be beneficial to help?
Yeah. So, I think that, you don't necessarily need to see a specialist to treat. In other words, if you have overactive bladder or bladder spasm, right,
Yeah.
you don't need a specialist urologist who treats endometriosis to fix that, right? Even temporarily, to address it temporarily.
Mm-hmm.
And a generalist can do that.
Mm.
What you need to be able to do, though, is describe your symptoms in a way that conveys to the doctor who's seeing you, the generalist who's seeing you, of what you're facing.
Mm.
Now, that's a tall order for a patient because the patient doesn't know what the doctor's trying to listen for, right?
Right.
Yeah.
So a good doctor knows how to sort of nudge you in the right direction and say, hey, tell me a little bit about XYZ. right? So like my opening line is always, why don't you tell me a little bit about your bladder? Is it nice to you? And the answer is always, well, what does that mean? And I said, it means whatever you want it to mean. You tell me.
Yeah.
And then, and then the floodgates open and you, no pun intended. And then you can sort of learn.
That was a good one.
That's right. Dad joke 101. So you can, you sort of have to, it's a tall order for a patient, but I think that if the majority of the symptoms that you're having are sort of, um, well, let me rephrase it this way. I think that if you can explain to the doctor in the most descriptive terms what it is that you're feeling, they should be able to put the picture together. What oftentimes happens, though, right, is you go into the doctor's office and the doctor has 3 minutes to talk to you, and they have an agenda that they want to push, and maybe you don't even get to say that part. So what I always tell patients is, I want you to come to the consultation, whether it's with me or anybody else, with a one-page executive summary, right, of what it is that's been happening with you. I don't want to hear no fluff, right? Like really bare bone stuff, bullet points, where I can say, look, I wake up, 6 times a night. I sleep, during the day. I'm exhausted because I've been up all night peeing. I wake up 6 times a night. Oftentimes I can't, even though I feel like I really need to pee in the middle of the night. I get up, I go to pee, nothing comes out. And I ask myself, what's going on? Like, if I'm a generalist doctor and you hand me that piece of paper, right, even ahead of the appointment, and I get to see that, I go, oh, wow, she's having nocturia, she's having urgency, she's having frequency. Yeah, we can put her on some overactive bladder medication. And it doesn't matter where in the world you are, overactive bladder medications exist and they're inexpensive.
That's good.
So, I would say the most important thing is to be able to communicate effectively your symptoms. And, if you're coming in emotionally charged because of medical trauma and you compound that with a doctor who's in a rush because they have another 45 patients to see,
right,
there's no way that you're going to get your point across.
Right.
Yep.
So putting pen to paper and doing like an executive summary, I think, is really helpful and beneficial.
That's a great point.
In terms of strategies to help patients while they're awaiting surgery, I think, overactive bladder medications are great. I say that with a little caveat that some of the overactive bladder medications, particularly the less expensive ones, can cause constipation, which is a problem in our patient population.
Yes.
And so on that executive summary, in addition to writing down what's happening with the bladder, you can also say what's happening with the rectum. And then if I'm the urologist, even the generalist, or even a GP, right, who sees, hey, this patient is having overactive bladder spasm, and she has incontinence, well, then this class of medications is not the right one, but this class of medications is.
Yep.
Right.
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 So overactive bladder medications are really broken down into 2 major classes of medications. You have the anticholinergics, which are the older class of medications. They've been around forever. They're very inexpensive. They exist worldwide. The side effect is constipation. The second class of medications is a relatively newer class of medications. It's called the beta-3 agonists. There's really only 2 drugs in that entire category. One is called Gemtesa and one is called Myrbetriq or Mirabegron. They do not have constipation associated with their side effect profile. So, that's, I would say that would be one thing that you could do. Pyridium, if you have a lot of burning symptoms, when you urinate, pyridium is a good drug, very inexpensive. Only downside is that it dyes the urine nuclear orange. And so if you have incontinence, it can stain clothing, and it can ruin a beautiful new toilet bowl. So you have to be sort of diligent.
You just get a black one. It's fine.
There's another medication called Urogesic Blue, which again stains the urine, just this time blue in color. And that's also a nice, it can sort of coat the bladder and sort of make it a little less irritated. Urogesic Blue is one, and then there's Urabel is another name. So, there's all sorts, it depends on the symptom.
Right.
And I think, again, any generalist should be able to pick up on sort of what it is that you need, as long as the symptoms are communicated clearly and effectively.
Right.
Mm-hmm.
And then probably always pelvic floor PT is always helpful.
Oh, 100. Listen, I'm a
Every
big,
single
big
time.
believer in prehab,
Yeah.
prehab, good intra, good rehab.
Yeah.
You have to have all three. So
Yeah.
Yep.
prehab is great. I think that it's sometimes challenging to do pelvic floor PT if you have stage 4 endometriosis with like a fixed frozen pelvis.
Mm-hmm.
You can't, sometimes pelvic floor PT requires internal work, and that's
Right.
not necessarily doable.
Right.
And so, just because you can't do the PT doesn't mean that you've done something wrong or that you're not doing the right thing. It's just some people cannot tolerate it.
Right.
Yep.
Right.
Right.
And for them, rehab is much more important than prehab.
Yep.
Yep.
Right?
But even getting a good baseline prior to surgery from the pelvic floor PT standpoint might be good, even if not much can be done, so that they know better what they're working with post-surgery for the rehab.
If nothing can be done, that's a very important data point.
Yep.
Right?
Yeah.
So if you go from being able to do nothing
Yep.
to post-surgical, you can tolerate internal work, that has big implications towards improvement in sexual function, urinary function, fecal function. There's a lot of good things that happen if you transition from a full-blown impossible pelvic floor PT patient to someone who, we have something to work with here.
Yep.
So that's all reasonable.
Yep. Well, thank you for taking your time out of your day.
Thank
and
you so much.
coming right out of surgery to see us and talk about this.
I appreciate it. Appreciate it.
Until next time, Endo Battery, continue advocating for you and for those that you love.